This.
Hello, everyone, and welcome to the Ohio State Comprehensive Cancer Center, Cancer Hospital, and Soul of Research Institute's Google Plus Hangout. In honor of Lung Cancer Awareness Month, we wanted to focus our chat tonight on lung cancer screening and early detection, including an overview of the lung cancer screening program here at the James, which is run by some of our lung cancer experts. Speaking of which, I would like to introduce Dr. David Carbone, medical oncologist and director of the James Thoracic Oncology Program. Hi, Dr. Carbone.
Hello.
And Dr. Pat Nana-Sinkam, pulmonologist and director of our lung cancer screening program here at the James.
Hi, Erin.
Hello. Thank you both for joining us tonight. So now we're going to get started, and we're just going to dive in. First question to start things off. So who is at higher risk for lung cancer, and who really should be screened?
Pat, why don't you take that?
I think I'll go ahead and take that one, Dr. Carbone.
Yeah.
So what we now know, based on several studies, but a large study that was published in just the last few years, is that there is really a specific group of individuals that are at highest risk for developing lung cancer, and those individuals are really defined by, number one, their age, being between the ages of 55 and 77, and then the second factor is that they've usually been a very heavy smoker, and we define that as 30 pack years. So what that means is either smoking 2 packs a day for 15 years or a pack a day for 30 years, and they either have to be actively smoking, or if they quit within the last 15 years. So that's really how we define the high-risk smoker.
Great, thank you. Dr. Carbone, is there anything else that you wanted to add to that?
Well, I would just add that while those people are at the highest risk, anybody with lungs can get lung cancer. And there are approximately 15 to 20,000 people a year who've never smoked, never had secondhand smoke, who get lung cancer anyway. Along those lines, things like secondhand smoke and radon exposure all add to your risk as well.
Thank you. So on that note, what are important things for people to consider when looking for a lung cancer screening program?
Sure. So we've been fortunate enough to develop a screening program over the last 3 years, and really it's been, I think, a very educational experience for us, and we've really managed to start to figure out what are the real components to a successful screening program. And when we look at our own program as well as programs around the country, it's becoming more and more evident what are the key criteria for an effective screening program. And I'll just outline those for you. Number one is really, it comes down to undergoing screening in a center that has the expertise, that's comfortable with screening. And what do I mean by being comfortable? Really, it comes down to the people. Having individuals who are comfortable with conducting screening, having a multidisciplinary team, because screening is really a team effort. It really requires having a group of individuals, all of whom are, number one, well educated on screening, number two, are passionate about screening and are willing to follow through on any abnormal findings, and then number three, really also having the infrastructure in terms of proper radiology, smoking cessation counseling, because one thing that I really want to emphasize is that smoking cessation is a key component to any successful screening program. It's really important that any screening program really be very comfortable with how to manage the findings on a CAT scan. It's very important for people to understand that CAT scans, I tell my patients that CAT scans are a bit of a double-edged sword. They're really good because they find a lot of things, but they can be very bad because they find a lot of things. And it's very important that in any effective screening program that there be a team of individuals who understand how to manage those findings and how to relay those findings to the patient. So I really would say that those are the components, I think, to an effective screening program.
Great, thank you. And so what can patients expect during their first visit? So let's give the James's lung cancer screening program as an example. What can they expect at their first visit?
Sure. So our screening program has really evolved over the last few years. And what we've really tried to do at the end of the day is make the program as comprehensive as possible and really provide individuals with a comprehensive view of screening. And what do I mean by that? So if an individual comes to our program to be screened, we recognize that the most important component up front is for us to first ensure that they really understand what it is they're about to undergo. So we talk about the shared decision making, and our shared decision making discussion takes place in real time at the time of the screening. And the components of the shared decision making include a discussion about, well, what is a low-dose CT scan? What does that mean to be screened with a low-dose CT in terms of radiation exposure? What does it mean when you get screened and you have a spot? What does a spot necessarily imply that you have a cancer? Absolutely not. So we talk about the issues of false positivity and the fact that most of the spots that are going to be detected in the setting of lung cancer screening are going to be proven to not be cancers. So it's important that we talk about that. And then really the third component in the shared decision making is the discussion around smoking cessation. I mentioned at the beginning that an important component to any successful screening program is that you have effective smoking cessation. At the end of the day, I tell my patients, if there's one thing that can come of this encounter, it's that you seriously consider quitting smoking and maybe you quit altogether. That's going to be the most important thing that you can do for yourself. So really it comes down to the shared decision making that takes place first. The second component is that then the patient, once they agree, they undergo a CT scan. What's different about our program is that the CT scan and the results of the CT scan are obtained on the same day. Why is that it's so important? Well, because there are many programs that do provide CT scans that can be conducted really at the patient's leisure, but then the follow-up becomes a bit of an issue because often it's in the form of a letter that comes to the patient, and we all know that CAT scans will have many what we describe as incidental findings, many of which patients won't really understand what the implications may be. So to try to address that, we do the CT scan and we review the results in real time so that when the patient leaves our clinic, they have a full understanding of what exactly is on their CAT scan. And then the last component that I think really distinguishes our program is lung cancer screening. I see lung cancer screening as a real opportunity for teaching, and teaching in the sense of smoking cessation. So what we are now incorporating into our program is on-site smoking cessation, so that if a patient states that they're interested in quitting smoking, we have the infrastructure to provide smoking cessation in real time, or at least provide the initial encounter for them right on the spot. So really, I think our program is I think slowly evolving into a comprehensive screening program with real-time counseling and real-time evaluation.
Great. So basically, can you just briefly, from a patient's perspective, they come to Ohio State and they come to Martha Morehouse, who do they see first? Who are the different clinical folks that they're going to interact with along the way? I know you've talked about smoking cessation, shared decision making. Who is doing all of those things?
So we think it's really important that the James physicians, our healthcare team physicians and nurses and medical assistants be fully engaged in the process from the beginning. So when a patient comes to our clinic, that shared decision-making discussion will take place with a James physician. It'll either be myself or one of my colleagues, usually a pulmonologist, so they will be seeing a specialist who is very comfortable with managing patients interested in screening and is also very comfortable with managing any incidental findings that may come up on the CT scan. So that shared decision-making encounter takes place with a physician. And then once the CT scan is performed, we then discuss the results. Again, the results are discussed with a specialist.
Great. So then what happens if cancer is found during a screening for a patient during the process?
So this is where having a program like the James, a multidisciplinary thoracic program, is so important, because once we see an abnormality where there may be suspicion that there's a cancer, it becomes very, very important that things be done in a timely manner. And having a program in which you already have a subspecialist from the James fully engaged in the initial evaluation can help expedite the process. So I've had cases where individuals may undergo a CT scan and they're found to have an abnormality, whether it be a lung or maybe another abnormality that appears to be cancerous. And that's where we have the opportunity to take advantage of having a multidisciplinary program where I may be able to either contact Dr. Carbone or contact one of our thoracic surgeons or contact one of our interventional radiologists. And in every case where a patient's had an abnormality, whether it be of the lung or somewhere else, we've been able to evaluate them in a very timely manner.
Right. So now also another question that I know a lot of people have been asking from a patient perspective is how does this affect insurance? Do most insurances cover the cost of the screening program at Ohio State, other screening programs? How does that work?
So that's obviously a really important question, and I think that is a process that's still in evolution. So approximately 1 year ago, a little less than a year ago, the United States Preventive Task Force and then subsequently and CMS prior to that both came out in favor of lung cancer screening. And once they came out in favor of lung cancer screening, that was essentially the trigger for there to be reimbursement, both from Medicare as well as from third-party payers. It's proving to be a little bit more complicated than we actually expected in terms of where does the reimbursement go to? Does it go to the CT scan? Does it go to the shared decision making? Does it go to the counseling session after the CT scan is performed? Just in this last few days, CMS, which oversees Medicare, they came out with guidelines for billing. And it appears that all billing will now go into effect, or reimbursement will now be applicable starting January 1st of 2016, retroactive to February of 2015. So CMS is really going to be leading the way, and now what we're starting to see is that many third-party payers, private insurers, are now starting to present their own policies for reimbursement for lung cancer screening. So it's still a process that's in evolution. Currently, we do not have a policy yet for reimbursement. All patients who undergo screening in our program pay a flat fee, but what we can anticipate seeing now that we've had this official document released by CMS is over the coming few months, increasingly there being reimbursement for lung cancer screening.
Great, thank you.
Sure.
Dr. Carbone, a viewer has asked a question who is a never smoker, and you had just mentioned that when we started, and the prevalence of those cases now. They have a family history of lung cancer, but are a never smoker themselves. So what does someone in that scenario do? I mean, if they can't, obviously there are qualifiers for the screening program, as Dr. Nana-Sinkam has outlined, right. And so they're obviously not able to just go and get a CT scan. So what is the protocol for someone like that?
Well, that's a very difficult question, and the fact is that lung cancer is common, so many people have relatives with lung cancer, and that doesn't necessarily mean that you're at an increased risk. There is a very rare syndrome associated with lung cancer that travels in families, and if you're concerned, if you have a very strong family history, I think visiting a genetic counselor would be a good idea to review that possibility. But the fact is that right now, CT screening is not indicated in people who've never smoked, in spite of the fact that many people who never smoke get lung cancer. So Dr. Nana-Sinkam and other people are developing blood tests, for example, that might be able to determine if you have an occult lung cancer. But this is still in the research stage and is not general practice. So that is a difficult question, and I think you should just be vigilant about symptoms. If you have a persistent cough that doesn't go away, or other symptoms that concern you, pain, in your chest. Blood, coughing up blood, of course, would be something. But beyond that, unfortunately, the current state of the art is that never smokers generally aren't recommended to be screened.
Now, is that the same scenario, or is it very different for someone who is a smoker and has been a smoker for a long time, but does not, fit the 55 to 77 qualifier, or is it a different scenario?
Well, it depends on insurance reimbursement. Often is very specific about smoking exposure, and I don't know if Pat wants to comment on it. So a heavy smoker who, for example, is 80 years old, or a heavy smoker who is 45 years old. Pat, do you want to talk about that?
Sure, sure. Well, yeah, it is a difficult question because occasionally I do see patients who come to my screening clinic or my regular pulmonary clinic who have a fairly strong smoking history, but they don't quite fit the criteria. There have been situations where I see patients and it turns out that they have a symptom that is of concern, whether, as Dr. Carbone was saying, they have a cough that that's been chronic, or they have some unintended weight loss. Those are situations where I think it's much easier to do an evaluation and start to look for an occult malignancy. For those individuals, however, who are asymptomatic, and it's really important that one of the criteria for lung cancer screening is that patients be asymptomatic. How that will be fully implemented remains to be seen, because the reality is many of these individuals who've been smokers have some type of symptom, whether it's some morning cough from having underlying COPD or some other symptom. But nevertheless, currently the guidelines are that an individual will be asymptomatic. So when I see patients who don't have any symptoms, have a heavy smoking history, but do not meet criteria, that's where we have to have a very personal discussion about the risk-benefit ratio of screening. And also we do talk about the potential financial implications and the fact that they may be in a situation where they have to just simply pay for their own CAT scan. I'm not averse to those patients if they have a heavy smoking history considering that, considering undergoing CT screening, but we do have a shared decision-making discussion about the risks and benefits. But in terms of insurance, if they're outside of the criteria, they have to understand that they are outside of the criteria and that they can't expect that there be reimbursement.
So you have to understand that about 85% of all lung cancers happen in people with a smoking history. And up until just a couple of years ago, even those people, even the highest risk categories of people would not be eligible for screening at all, in spite of the fact that we normally would screen people for colon cancer, for breast cancer, for prostate cancer. Up until a couple of years ago, nobody was eligible for screening. So I think this is a major advance in the trying to reduce the morbidity and mortality from lung cancer. But it's just the first step. We do need to figure out more effective ways to reach more people and detect more types of cancer. And maybe backing up a second, what is the purpose of screening? It turns out that most lung cancers are diagnosed when they're incurable. In fact, about 70% of lung cancers are diagnosed when they're incurable, or they're already spread outside the chest. The best treatment for most types of lung cancer is surgery. And so the whole point of screening is to find tumors when they're small and surgically resectable or treatable with localized radiation. The lungs themselves don't have nerve endings in them, so people can have reasonable sized tumors in their lungs and have no symptoms at all. And the point of screening is to try to identify the people that have the highest risk of having these asymptomatic lung cancers that wouldn't be detected normally until they become metastatic. But instead, if you do a screening CT, you find these when they're curable at an early stage.
Yeah, that's a great point. Thank you for making that, because I know that that's something that's obviously not been addressed yet, and I'm sure a lot of people are wondering about. And on that note, can you just kind of talk about, either of you, both of you, what kind of sets the James's program apart in terms of the lung cancer screening and the comprehensiveness of the lung cancer program, that makes it so unique?
Well, Pat has already addressed that, but maybe I can just reiterate it, that very few screening programs involve a visit with a physician or on their first visit and a same-day evaluation of the CT scan. Many times you come in, you get a scan, you go home, and you wait for a letter in the mail, and the letter will suggest that you make an appointment to see somebody. In our clinic, we have the scan, get the reading the same day, and meet with the pulmonologist the same day. And we operate in a multidisciplinary environment, so the pulmonologist who reads the scan can directly consult with either a medical oncologist like myself or a thoracic surgeon, hopefully, to initiate treatment discussions if something is found.
Yep, and that's I guess a better way to have addressed it is the multidisciplinary approach. You know, obviously, Dr. Nana-Sinkam has talked about the overall lung cancer screening program, but then, you know, going on and moving throughout the lung cancer program at the James, aside from, you know, the program, just talking about that multidisciplinary approach that, you know, you just mentioned.
Right, and the other thing I'd like to add, Aaron, is that the other aspect that we don't always talk about in the setting of lung cancer screening is that it also represents an opportunity to at least start to address other smoking-related disease that carries significant burden as well. So I want to mention that among the patients that I've seen so far in our lung cancer screening program, we've probably seen about 25% of our individuals who were screened were found to have some form of chronic obstructive pulmonary disease, and they did not know it. They did not carry that diagnosis. And it was only after we discussed the results of their CAT scan that they started to tell me that maybe they did have some symptoms that were suggestive that they've been living with chronic obstructive pulmonary disease for many years. And we have the opportunity, because these patients are in our midst and they're seeing a James physician, a pulmonologist, we have the opportunity then to actually provide them care that may have never really come to their attention that they need it at a much earlier time. The other point is that among patients who have COPD, we now know that when an individual is diagnosed with COPD, that in and of itself actually carries about a 2 to 3-fold increased risk of developing a lung cancer during their time. It is now an independent risk factor, aside from smoking, aside from asbestos, aside from family history. If you have COPD, you are now in what we describe as an even higher risk group. These are also the types of people that we have to capture and manage their COPD, offer them good quality of life, make sure they're on proper medication, and then really make sure that they stay in our system so that we can identify any early lung cancers.
So the other distinguishing characteristic that I also wanted to emphasize really is experience with evaluating lung nodules. In many screening series, about 30 or 40% of people getting screened in this high-risk category have some kind of lung abnormality. And in centers where physicians are not experienced at evaluating these in a multidisciplinary way, sometimes of these 30 or 40% of patients, only 1 or 2% will have lung cancer, and you want to avoid unnecessary interventions for nodules that are very unlikely to be lung cancer. And if an intervention is necessary, you want to go to someone who does 20 or 30 procedures a week instead of 2 or 3 a month. And so I think the experience factor has to be calculated in there.
That's exactly correct. I agree. That's exactly correct. And we have seen in our own program that about 30%, maybe a little bit more than that, of the individuals who come to be screened end up having some type of nodule or spot on their lung that does, in fact, require closer follow-up than a standard annual CT scan. And one of the advantages of our program, the James program, is that we have a very clear algorithm, a very clear plan for management of individuals who may have a spot on the lung that, one, may not require a biopsy at this time, may not require that it be removed at this time, but they do require very close follow-up with a specialist. And so in those cases, those patients end up becoming James patients, and then we follow them along. And when we feel it's an appropriate time that they may require an intervention by one of our colleagues who is a specialist, then we do that. Or if they require closer follow-up or continued monitoring, we also have the proper infrastructure to do that. And that's very important in any screening program, is that not only that you be able to screen individuals, you identify and you screen them, but that you really have an infrastructure in place to manage those 30 or 35 or 40% of abnormalities that do in fact come up, and that you don't subject patients to unnecessary biopsies, or on the flip side, you don't necessarily ignore a nodule that needs to be followed at a proper interval so that it does not go on to become a more advanced cancer, as Dr. Carbone was alluding to.
So that's probably a good segue into maybe expanding more on the fact that we hear all the time now that early detection is key in preventing and treating cancer. What does that mean for lung cancer patients in specific? I know you talked about a lot of like the COPD as being a key factor now, all of those things. What does that mean for lung cancer patients in specific?
Well, first, just for clarification, early detection doesn't prevent lung cancers. It prevents deaths from lung cancers. It allows you to find lung cancers when they're curable. So it shifts the time that at which a lung cancer is found. Prevention of lung cancer generally is best accomplished by smoking cessation, and the kind of counseling that Dr. Nana-Sinkam was talking about is key to that, and also interaction with family members and getting family members involved in that decision to prevent lung cancer by reducing cigarette exposure.
Great. Anything else to add, Dr. Nana-Sinkam?
No, I agree wholeheartedly.
Wonderful. So is there anything else after all of these questions that we've had, is there anything else that you feel is important for people to note about screening and early detection in the last few minutes that we have left?
Well, I guess the one thing that I think has been emphasized is that ultimately the most important intervention that we can make for patients is to encourage them and provide them with the infrastructure to quit smoking. I think that is one of the areas in which our screening program has the potential to have real impact. Not only the screening with the CTs, which is very important, but really getting individuals to modify their lifestyle so that they can, over time, hopefully decrease their risk for getting not only lung cancer, but also developing other significant smoking-related diseases, such as heart disease and chronic obstructive pulmonary disease and so forth.
I think that's definitely true. Like you said, you can detect people who have lung disease that was not suspected by the patient. But I also am very encouraged when we find that small lung cancer, that tiny spot that's asymptomatic, and we can treat it and cure it, and the patient never hears from that again, instead of seeing me 2 years down the road with metastatic disease. I think that's very satisfying for the patient and for me personally.
Well, thank you both very much for sharing your time and your expertise with all of us. Thank you for everyone who joined us. And if anybody has any other questions that weren't addressed here, feel free to visit our website at cancer.osu.edu and follow us on social media. And other than that, have a great night and happy Lung Cancer Awareness Month.
Okay, thank you.
Thank you so much.
Good night.
Bye.
Bye.